Hello, everyone. If you're just joining us right now, my name is Mimi Swartz, and on behalf of Texas Monthly and the Texas Business Hall of Fame, I'd like to welcome you to our latest Texas Town Hall with Dr. David Callender. Dr. Callender is president and CEO of the Memorial Hermann Health System, one of the leading healthcare providers in Southeast Texas, and a health system at the heart of Texas' hardest hit county. Welcome, Dr. Callender, and thank you for sharing your healthcare perspective on COVID-19 with us today. I'd like to start with a question that is really twofold. What would be, if you had a message for the business community today, what would that be? And how would that message be different for members of the Texas business community than in other states?
Well, I think in general, it's thank you very much for working with people across the state to flatten the curve, to reduce the number of COVID-19 illnesses and related deaths. Everyone's put their lives on hold, put their business interests aside, and enabled us to reduce that impact. And so we're very pleased with it. I think what makes us different as a state is that we're so big. We're spread out. We're very diverse in terms of the nature of the communities in which we all live. And that means that we have to, while using the same guidelines in terms of how we manage our lives in the face of this virus, we have to adapt our approach based on what's happening around us. And that's the key to success as we go forward.
I realize that most of the people in Texas still live in, or do now live in, urban centers, but what are you seeing in rural communities? Has it hit there? Do you think it's not going to be as bad there? What's your feeling about that?
Well, it's certainly, if you look at the counties, the 254 counties in Texas, 198 have at least one positive case. So that means 56 have no cases at all.
Yeah.
And so again, I think if you look at my hometown, Wichita Falls, it's having a very different experience than what we're having here in Houston. And so again, we need to take that into account as we plan how we reopen and try to move back towards more of a state that resembles normal.
Yeah. And what does normal look like? Have we hit the peak, do you think?
Well, I think we're probably close to the peak if we haven't hit it already. We use this concept of a peak based on the models of how the virus may spread. So we're really not going to know we've hit the peak until it's already behind us. That's okay. It's a good time to start thinking about, okay, what does the new normal look like as we go forward? How do we get our schools open? What happens in terms of reopening retail businesses, restaurants? What about sports, high school, college, professional sports? So all of those things need to be considered. Now's the time to do it. And we think we can safely do all of those things if we just plan carefully about how we do them.
And when you say plan carefully, does that mean a much more gradual approach to opening? What? More social distancing, everybody in a mask?
All of those things, we need to maintain the appropriate level of social distancing as we go forward. Certainly the more vulnerable members of the population, those of us who are older, or those of us who may have chronic diseases, may want to reduce the amount of circulation that we do and try to avoid those higher risk contexts. But again, we think that we can get schools open, we can protect teachers, we can protect students. We just need to think about how we do that. And then as we execute our plans, monitor what's happening and be ready to adjust on the fly.
When you say schools open, are you saying end of August, early September? Not
That's a reasonable goal. Again, we need to think through that. And it might be different for some of the larger school districts than it is for the smaller ones. And so again, this is where the nature of the context comes into play. I think what the governor wants, and I certainly agree, is that we develop a playbook that outlines the ways that we can safely interact with each other using mask, appropriate social distancing, appropriate levels of hygiene, personal as well as public. And then we use the different elements of the playbook, adapting them to the situation or context.
Mhm. And what about underserved communities? How do you get the message out to people that may not be watching this show and who may be more susceptible to other illnesses?
Well, you raise a critical aspect of
Uh-huh.
restarting the economy in a safe way.
Yeah.
We'd like to see a massive education effort started
Uh-huh.
that helps everybody understand how we live with this virus, how we coexist safely going forward. We also think we need to employ more testing. We need to look
Yeah.
at areas where there's a higher risk population. We probably need to have public health workers out circulating in those
Yeah.
communities among those higher risk groups, doing personal education or group education, and then following through to make sure that we're doing our best to limit the spread of the disease.
And so whose responsibility would that be? I mean, we have to get those organizations up and running, right? They
Yes,
don't exist
they do
this
not
moment.
exist today, and
Uh-huh.
that's advice to the governor that's being
Mhm.
considered at the state level as well as by elected officials and business leaders across the state. So how do we put together that
Yeah.
public health workforce?
Mhm.
Who do we employ? How do we get them trained? How many is the
Mhm.
right number based on the at-risk communities, the size, the numbers of people? So all of those things are being considered. We understand the principle. Now we have to figure out how to implement it
Right.
or use it.
Right. One of the things that a friend brought up to me is that Texas has a shockingly low death rate for our population. Can you talk about that a little? I assume there's some good news there and some more questionable news.
And I missed part of that, Mimi. So shockingly low
Death rate.
death rate
Yeah.
relative to the
To,
disease.
to the population. Yeah.
Yeah, and there are a lot of things that we're observing that we don't quite understand. And
Mhm.
so we can guess, we can create hypotheses now as to why our experience in Texas may be different than that in other areas, states, and countries, but we just don't know. We're very happy to see that we have a lower mortality rate
Yeah.
in the general population. But then
Yeah.
also, if we look at various segments of the population, we have a higher death
Yeah.
rate than we should. So for example, with the African American population. And
That's,
so there's some
yeah,
things
we
that we
just
don't,
got a question.
yeah, we don't quite understand yet. It
Mhm.
certainly could be related to the higher rate of comorbid illness. And when I say that, I mean things like
Yeah.
diabetes, hypertension, heart disease, and the like.
Mhm.
But again, that's conjecture at this point. So we have much more to learn.
Mhm. Mhm. That's fascinating, I think. How long do you think we're going to be living with this virus? Do you expect it to come back? I've heard people talk about how it might come back in the fall, like the flu epidemic in 1918.
Yeah, we think we're going to have to deal with cycles of the
Mhm.
disease as we go forward. We think as we begin reopening, restarting the economy, we may see a little uptick in terms of the
Uh-huh.
overall number of cases. And what we want to do as we go forward is to again be monitoring what's happening, be
Yeah.
prepared to adjust our plans as we go forward
Uh-huh.
based on the incidence of the disease, what's happening, making sure that we maintain a capacity in our health system to deal with the sicker patients.
And when you say monitoring, what does that look like? Is it taking the temperature of everybody who goes in a building? How does it work?
Yeah, different levels of monitoring. Certainly, as a health system, we're monitoring the numbers of patients that we're seeing
Mhm.
and admitting to our facilities. So that's an important indicator Those numbers are regularly collected across the state so we can monitor what's happening in terms of people requiring hospital admission or health care. We like to have a much more significant testing capacity. In fact, one of the things that's been recommended to the governor is that we develop a statewide database that collects the number of positive patients and their locations so we can monitor what's happening over the course of time and direct some of our precious resources to those areas that may be hotspots relative to other areas of the state. Some businesses may be monitoring the temperature of employees as well as patrons as we go forward, particularly as we begin the restart. So there are a number of different ways we can use to monitor what's happening. They all have usefulness and validity, and it depends on the context.
Yeah, it's fascinating. I mean, we're sort of in uncharted territory, right?
Very much so, unfortunately.
Yeah. I have a question from Lexi, who wants to know, will hospitals be resuming elective procedures by the end of the month? And in terms of trickle-down impacts on vendors, when will normal relationships resume? And can you talk about the overall impact of this crisis on that sector?
Wow, that's a complicated question. Well,
yeah.
all of us have focused our capacity on managing COVID patients, particularly given there's so much uncertainty. We didn't know what to expect in terms of a surge. And everybody across the state worked very hard to make sure that we maintain the capacity of our health system in the state to manage patients who required admission to the hospital. We've done a very good job with that. We now have capacity in our hospitals to start resuming more of a normal business. And, unfortunately, COVID didn't put hypertension and diabetes and heart failure and other things on hold. Patients have been waiting for us to resume their treatments, their diagnostic procedures, in some cases surgical procedures. And so we also are thinking about how do we do that safely. The governor's most recent order allows us this week to begin resuming some diagnostic and low impact, low risk therapies. So we will do that. Again, we'll monitor our response. And then as we go forward, making sure we have adequate capacity, we have adequate PPE in case we get another surge, gradually ramp up our activity to go back towards what we consider meeting the normal demand for healthcare service.
With that, my question is, how does that impact the medical sector financially? I mean, your bread and butter are these elective surgeries, and I don't mean plastic surgery. I mean, heart disease, cancers. That's how hospitals survive and thrive economically. So, what kind of balancing act are you looking at between watching the epidemic and trying to survive financially?
Our first concern is always making sure that we're providing the service that's needed in accordance with the public standard and public need. And I think all of us have done a good job of that with COVID. We have, like everybody else, paid a big price in terms of financial impact. A lot of the really smaller hospitals are struggling right now. We need to try to figure out how to help them get back on their feet. Again, as you know well, we've got a very complicated system for funding healthcare. And we need to be able to generate revenue to make sure everybody gets the healthcare they need. And so we're like everybody else. We're anxious to get restarted. But again, our first concern is the safety of the public and addressing the immediate need. And so we're creating plans to move back towards normal, like everybody else, monitoring what happens, making sure that we don't on our own cause another surge.
Right. Oh my God. Well, I have a question from Veronica, who's asking again about African-American communities. You want to run back over that again?
Well, one of the things we've observed is that the mortality rate among African-American patients with COVID-19 is higher than that of people with other ethnic backgrounds. And we don't completely understand that. So we're very concerned about it. We're gathering more information. Certainly is an area of active investigation, and that will go on, and that level of investigation will increase over the course of time. Our working hypothesis, theory, if you will, is that in general, the African American community has a higher rate of comorbid illness, so things like hypertension, diabetes, other forms of chronic illness. We know people who have comorbid illnesses tend to fare worse when they become ill with COVID-19 or with the SARS-CoV-2 virus. And so that's where we are today. But again, we have much to learn about this. And certainly as we go forward, we already know that population seems to be at higher risk. So we need to develop better, closer monitoring strategies for any population that's at higher risk, try to more directly engage and see what we can do to normalize the mortality, the impact, all of those things that are associated with COVID-19 illness.
Is the rate of illness higher in African-American communities as compared to other minorities, the Latino community, for instance?
You know, that's hard to say right now. It's interesting looking at the demographics around our state, the, if you will, attack rate, the percentage of each of the populations that's developed the illness. By and large, it mirrors the demographics of the state, but doesn't perfectly reflect the demographics either. It's a little too early, I think, to make broad judgments. So we see some interesting outcomes, some interesting what perhaps are trends, but we just need more information to understand what those mean and how they will play out over time.
I have a spreadsheet question from Ginger Davis, who wants to know if you are anticipating a second outbreak in the fall.
You know, one of the challenging things is, again, we don't have any experience that we can fall back on that helps us make really great predictions. We believe right now that as we start circulating more as a society, as we attempt to restart our economy, we will see another surge or additional surges in the numbers of cases. And so what we want to do is to monitor what's happening and adjust our plans for restarting or for being out in public together, particularly in gathering places, based on our ability to accommodate surges. So I guess another way to think about this is just because we're on the other side of the peak doesn't mean this virus is going away. It's going to be with us for some time. The most effective approach to managing it over the course of time would be with a vaccine. There's some promising work being done with vaccine development, but it's too soon to actually say we're going to have a vaccine that will be effective against this virus.
How long, what do you think a reasonable timeline for a vaccine is?
Well, I am a great fan of Dr. Tony Fauci. I've had the opportunity to meet him in person in the past. He's very bright. And I think what Dr. Fauci has said is generally true, you know, at the earliest in terms of being able to broadly use a vaccine, we're probably at least 18 to 24 months away. And most likely it's longer. We have a number of vaccine development programs in this state. And the leaders of those programs are saying Dr. Fauci perhaps is a bit optimistic.
Oh my goodness.
Probably, 2 years. And so again, in the meantime, we need to learn how to survive, coexist with the virus and the COVID-19 illness.
Well, I have a question now from Ashley, who is asking you, as a healthcare provider, what's been your greatest lesson learned so far?
Um, to constantly look at what's happening, to assess sometimes on an hourly basis the data that's coming in about what's happening, making certain that we're using the data effectively, and also that we're planning effectively.
Uh-huh.
We're thinking ahead. Now, those really aren't new lessons for those of us in healthcare, but in a case like this where you just don't have any experience on which to base your plans, you need to be very creative, looking forward, create a number of different outcome scenarios, and be able to accommodate operating in any one of those scenarios. So in this particular case, again, thanks to the people of Texas, we've done pretty well in terms of staying within our limits, limiting the impact to the population, and preserving capacity of our healthcare system.
Yeah. What does, your morning look like in terms of coordinating this effort? Are you on the phone all the time with, people who run other hospital systems in the state? Are you on the phone with the governor? How is it even working?
Well, I think we're all busy. I start my day every morning, at least in terms of meetings, at 7 a.m. with the CEOs of the other healthcare systems that are based in the Texas Medical Center.
Yeah.
And we compare the latest information, data. We talk about various aspects of what we're doing, trying to continue our collaboration, our joint thinking and planning, and then move on from there to meet with members of my team via Zoom or via teleconference. We're constantly in communication. And going back to the question that was asked before, monitoring what's happening, using the information to adjust our current plans and adjust our plans for the future.
Do you think this will change the character of the medical center going forward? I mean, most of these hospitals historically have been somewhat competitive with each other, and this is almost sort of, it has to be collaborative for the public health. Do you think going forward you'll be a more collaborative organization or series of institutions?
I think so. I think we've learned a lot about the value of collaboration. That said, and I'm imagining my colleagues sitting here with me, we're all friends. And there is a high level of trust among us. We do communicate regularly. I think we'd all laugh and say, we're always going to compete. This is Texas, But, we do that, I think, in a way that serves our community very well. And I think, again, we've learned some good lessons about the value of collaboration, or we've seen the value of collaboration demonstrated during the management of this crisis. And so that's never a bad thing.
Yeah, well, good to hear. I have a question. Someone would like to know, how are you supporting non-clinical employees?
Well, I think every system has a slightly different approach. For our folks who don't really have something to do right now, we actually have guaranteed them 75% of salary. So if they've been called off, we're providing support for them. Now, because we are delivering healthcare, we're using most of our people. They've all signed up in the labor pool, and we're moving them around to meet the most urgent needs. So a lot of our people who don't report to their regular place of work are doing other things for us. But we certainly have a few who have been called off, and we're anxious to get them back to work, going back to the question earlier. But right now they're still with us, and like all of us, thinking about how do we move on from beyond where we are today.
Do you see, this is a similar question, do you see innovation from this crisis in terms of non-clinical healthcare jobs, different kinds of jobs that are going to come out of this?
I think there's innovation across the board. You know,
Yeah.
you always learn in times of crisis. And one of the biggest things we see is this use of technology
Hmm.
to bring people together across broader distances, how we manage more effectively with technology as the support for our meetings as opposed to in-person meetings. We've
Yeah.
markedly increased the use of our telehealth approaches in terms of regularly maintaining contact with our patients, checking in on them, allowing them to contact us without having to come into one of our outpatient centers. And so we've learned a lot from that and are planning for a more extensive deployment, if you
Hmm.
will, of telehealth resources as we go forward. So yes, we're certainly learning and want to take advantage of the learnings as we move back
Yeah.
towards normal.
I would think it would be enormously helpful in rural communities where, you know, there's so few doctors and so few hospitals. You think that'll be one of the things that lasts?
Yeah, absolutely. And the good news is in Texas, because we are so spread out, we
Hmm.
were already using telehealth resources, particularly for the delivery of mental health care at a
Hmm.
distance, providing some support services. For example, reading x-rays or
Oh,
diagnostic imaging studies. So those can be basically digitized and sent to a remote location.
mhm.
The radiologist doesn't have to be in a small hospital in a small city in Texas. So we
Oh,
were already doing some of that, and we've been doing more with COVID-19. And again, we think those things will stick and be with us as we go
yeah.
forward.
It's fascinating. At least something good is coming out of this, I hope.
Absolutely.
Um, let's see. Here's a question from Gabriella. Do you think that healthcare systems will coordinate more closely with public health entities moving forward?
Yes, and I think we have to.
Mhm.
You know, again, we need to learn how to live with this illness. The public health resources in Texas are not what they need to
Yeah.
be as we go forward and figure out how to live with the virus. I think health systems can offer a lot in terms of support for the public health work. In some cases, we may directly support it. We may subsidize it for a while. We
Uh-huh.
certainly want to be in close and regular communication with the public health agencies, beginning with the Department of State Health Services in Austin,
Mhm.
and extending that out through the county health services and the public health officials. That is also one of the benefits that
Yeah.
we've realized with COVID-19. We have been working very closely with our public health officials and agencies here in the greater Houston area and
Mhm.
across the state.
Well, that's another change I'd like to see, I think. Um, so here's a question from Sarah. What new clinical systems have been implemented to help with patient care during COVID?
Well, again, I think the biggest issues for us are really about how we maintain contact
Yeah.
with patients who cannot come into one of our outpatient centers or who have a chronic illness that otherwise would require a semi-elective procedure, who can't get that procedure now. And so staying in regular contact, doing everything we can to help them be managed at a distance to manage their symptoms and illness manifestations while we're waiting to be able to see them again. So we've made significant strides on that front. So very happy to see that. I think also just thinking about how we live with the virus going forward, we now understand the importance of having very well established and maintained supply chains for
Huh.
things like PPE,
Mm-hmm.
for ventilators.
Mm-hmm.
And so I think, you know, that's something we've thought about a lot
Yeah.
as a group of healthcare professionals, but clearly the public health officials, our elected leaders also thinking about that. I think we'll see changes on that front too as we go forward, a significant bolstering of not only the national stockpile, but of the national manufacturing capacity
Yeah.
to build and distribute a lot of those things that are necessary in the face of a pandemic.
And whose responsibility would that be going forward?
I think this is where the concept of public-private partnership really comes into
Yeah.
play.
Mhm.
For example, at the state level, one of the things that's been proposed is that we have this database, a clearinghouse that we all can use
Mhm.
that allows us to track the levels of PPE, that allows us to maintain a list of the firms that compose the supply chain
Mhm.
for the elements that we need, that we're focused on collaborating together to
Yeah.
create, for example, orders that are large enough in bulk that they are likely to be acted upon by the suppliers.
Uh-huh.
And so, again, I think those are the sorts of things that we'll see going forward, that will be a combination of public actions and private actions that are coordinated together to help us do a better job.
Mhm. Is Texas, how how well equipped were we at the beginning of this pandemic with PPE and with ventilators, with equipment? I mean, did we have to go out on the open market like other states, or was there enough here?
No, I think everybody would agree, and I don't mean any criticism in
Mhm.
making the statement. By making the statement, we weren't prepared for this.
Yeah.
Our health systems had the supplies of PPE and ventilators that are necessary to do what we typically do.
Yeah.
Now, we all had pandemic plans
Mhm.
that were fleshed out to some level of detail, but those plans really weren't supported by assurances that we had stocks of PPE, a supply chain that could help us get what we needed, those sorts of things. So that's an important part of the response to this.
Yeah.
Thinking about this is probably, unfortunately, not the last pandemic that we will
Right.
face.
Right. Uh-huh.
And so we need to be prepared going forward to respond to any sort of pandemic
Mhm.
that pops up in future years.
And there will be more. It looks like historically, there's no way to know what kind, though, correct? Is there any way to predict?
That's correct. Now,
Yeah.
we've been thinking mostly along the lines of a pandemic flu.
Mhm.
And perhaps maybe we were a bit complacent because we're all comfortable
Mhm.
with flu.
Yeah.
Again, that's some speculation on my part and perhaps not very accurate, but now we understand
Yeah.
what a pandemic can do, about the
Mhm.
terrible impact
Yeah.
to personal lives, causing illness and death,
Mhm.
hamstringing our economy. And so hopefully that will motivate us to be better prepared.
Mhm. It's fascinating. I have a question from Jeannie. Why did it take so long to recognize the threat of silent carriers of COVID-19?
Really great question. All these questions are great. Thank you all. One of the challenges that we've had is that we just haven't had the testing capacity
Mhm.
that we would like to have. That was certainly true at the outset of the illness. We were seeing lots of patients who had symptoms consistent with COVID-19, but we couldn't get them tested.
Mhm.
And so we sent them home to self-quarantine. We called and checked on them, monitored them. And then in some cases, if they required admission to the hospital, we could get them tested, although the delays in getting the results were often several days. Fortunately, we've moved beyond that now, but we're just now really beginning to understand that there are a significant number of asymptomatic carriers of this
Yeah.
disease. Some people
Uh-huh.
seem to have had it and had minimal or no symptoms.
Yeah.
In other cases, people have had it for 3 or 4 days and been shedding virus, not aware that
Uh-huh.
they were doing so and showing no outward symptoms. And so again, that's in that category of things we need to better understand
Mhm.
as we go forward so we get a better handle on how to manage this illness.
Is this unique to viruses, to this virus specifically? as opposed to flu. I mean, with a conventional flu, say you're fine one day, the next you're really sick. With something, are there carriers of what I think of as conventional flu who are asymptomatic?
There are a few, but nothing to the extent that we've seen with COVID-19.
Yeah.
And so it seems that most people with the flu develop the symptoms. We know that they're contagious for a while. There's what's called an R factor, which is how transmissible an infectious disease is, or describes how transmissible it is. And with flu, the R factor is much less than it is with COVID-19. So that's what makes it such a scary problem for us. We don't always know who has it. We haven't, at least to date, had the testing capacity we'd like to have. The testing isn't perfect. Sometimes we can't tell you what a negative test really means. So the predictive value of the negative test is not what we'd like for it to be. So again, these are all areas for further work and investigation as we go forward. We do think that we need to employ broader testing in the coming days, particularly as we seek to restart the economy. We believe the testing capacity is coming up nicely. We want it to grow beyond what it is today. But we believe between public sources and private sources that we can focus, at least initially, on those areas of restart, on those businesses that are higher risk, on those populations and say areas of Greater Houston, for example, that may be at higher risk, and deploy our testing capacity selectively so we deal with the highest risk areas.
It's a real challenge, I think. Here is a question from Gabriella. Do you feel the rollback in CMS telehealth laws will remain in place post-COVID? And maybe if you could first explain what the telehealth laws were and then how they were rolled back.
Well, the challenge for us has been the reimbursement that is received by healthcare providers for telehealth services has either been non-existent are very low. And so that's been a challenge in terms of employing the technology to do the things that we've been doing during COVID. I guess the best answer to the question is we certainly hope so. We hope that the levels of reimbursement will continue, the types of reimbursement. We'll be able to do many more things with telehealth resources than we've done in the past and be appropriately reimbursed.
I have a question from a Peggy Dietermeyer. What are the expected ramifications for delaying what I want to say are conventional surgeries, heart surgeries, cancer surgeries, what you would normally be seeing?
Gosh, it's hard to give a really confined answer to that. I'm not very good at confined answers anyway, so I apologize.
I'm delighted.
Cancer surgery and heart surgery typically are two types of surgery that need to be done that really shouldn't wait. And so in general, the governor's original order allowed us to do those sorts of procedures if we felt that the patient's life was in danger or there would be a significant risk in delaying the offering of the procedure. So in most cases where those things have been necessary, we've proceeded to do them. But for example, a diagnostic procedure in a patient who we're suspicious might have early cancer could have been delayed. And so we don't want to delay those any longer. We're anxious to get those done. A diagnostic heart catheterization for someone who's had atypical chest pain, which is stable, it hasn't gotten any worse, but still implies risk for the patient, needs to be done. And so we're anxious to get those sorts of procedures restarted also. So I guess bottom line is we've postponed things that need to be done soon. And we're now planning on getting those things done, protecting the patients actually testing them before they come in, are giving them a period of time to show us they don't have symptoms of COVID-19 before they present for their procedure, making sure that our employees are tested, that they're COVID-19 free,
Yeah.
and then doing it in an environment that protects everybody who's involved in the delivery of that service or procedure.
I think there's a question that relates to that from Chad. Are hospital systems looking at new sanitation technologies for entire hospitals rather than just operating rooms?
Yeah, and this is something we were doing anyway. You know, particularly given the thing we worry about, which is an infection that might be acquired in a hospital. Microorganisms, viruses live on surfaces, some longer than others. Fortunately, we're used to this, and we have pretty regimented, high-level disinfection practices in use in our hospitals, but we can always improve. And so there are cleaning robots that use UV light that are now being employed, UV lights in procedural areas, other new approaches that allow us perhaps to augment what we're already doing. And so that's a never-ending effort for people who are in healthcare, not only in hospitals, but in outpatient treatment areas too, or diagnostic areas. And so I certainly expect that to go on.
Boy. Here is a question from Charmaine, which is somewhat similar to one that's been asked before, but I think it's a good question. Knowing what we know now about this first wave of the disease, are we in a better position for a second wave in terms of treatment?
You know, unfortunately, we really don't have treatment methods that truly reverse the course of the illness. We know there's some agents that seem to be promising, but essentially the principal treatment is supportive care.
Wow.
Trying to keep people healthy, keep their disease from progressing when they do develop pneumonia, treating them so that they can maintain appropriate and healthy levels of oxygenation. It's probably going to be a while before we prove that any of these promising agents will work well in some or all COVID patients. So again, the key to success as we restart the economy is carefully monitoring what's happening. If we see outbreaks, working to control those, do testing of the populations that seem to be at highest risk, use isolation. Perhaps even some level of quarantine for those people who are positive, are at high risk. So focused social distancing, if you will, until we see control in that area and then moving on beyond that. So basically what we've already employed, we know works, and we're going to try to optimize our use of those approaches, particularly as we start to get the economy working again.
So I'm trying to envision that this is, I suppose, if we have this public health army, then they will be the ones who will be checking these neighborhoods, checking various offices, whatever, and then reporting back as quickly as possible if there is an outbreak?
Yeah, I think essentially that's a nice summation. Now, one of the things, again, thinking about sort of the public-private approach to this, I know a number of businesses, organizations are planning on their own approach to testing their employees. They want to minimize risk for their employees. They want to minimize risk for their customers or patrons. And so they're likely going to employ a testing and monitoring approach on their own. And we certainly support that and are happy to provide advice here in Houston. The local healthcare providers are engaged with the local chambers of commerce, thinking about advice that we give to different businesses in each of the economic sectors about how they safely reopen. And so, again, I think there's a role on the private side as well as on the public side. And it's the combination of the two approaches that will yield the best outcome.
Yeah. Wow. I have a question from Shannon McClendon. Do you have higher overhead costs with fewer elective procedures? At least in the case of Memorial Hermann, are your hospitals more strained, or have services just shifted?
Yeah, well, we talked about this a little earlier. There's a financial strain on all healthcare providers with the social distancing approach that we've employed. Overhead just reflects cost, and what we've seen, because the cost of PPE have skyrocketed and we've had to maintain an adequate supply. We're certainly seeing a higher cost per patient admission, and that's related to a combination of the PPE supplies, the high percentage of patients requiring intensive care, more expensive to care for those patients, needing to use our labor supply in a more intensive way. So all of those things have driven up our cost during this time.
Boy, I have one slightly tougher question I'm going to ask, because I keep hearing it in my head. So would something like the Medicaid expansion be helpful at this time? I mean, we're seeing Washington having to look at expanding social programs because of the pandemic. What about here? Would something like that help or not?
That has so many political overtones.
I'm sorry.
What I'd like to see is that Texas doing a better job in managing social disparities, in addressing our problem associated with such a high percentage of our population being uninsured and not having adequate access to care. There are a number of ways that we could go at that. Our elected officials certainly are the policy makers when it comes to creating systems to do that. I think we have a lot to offer as healthcare professionals and as citizens in thinking about how we do that. I do feel strong, and this is a personal belief, that unless we address the issue of those who don't have adequate access to healthcare, our state is going to suffer economically. We will not have the workforce that we need going forward.
I think that's a great answer. Here is another question from Veronica. Do you see a permanent shift in medicine coming from being treatment focused to prevention focused?
Well, I think that shift in terms of the shift to prevention, I think we were already there. We understand that in terms of return on investment, a dollar invested in prevention buys us a lot more than a dollar invested in treatment. Now, that's not to say we can totally turn to prevention and ignore treatment, but we need to do more on the prevention front. We, particularly from my perspective, need to get into the communities that we know are at higher risk and get more engaged with those communities. They don't want us telling them what to do, but if we are invited in and we can create a conversation about what we can do together in those communities to improve health outcomes, I think we can be more successful than we have been in the past. Certainly that's a focus of my system, trying to engage in those conversations and work through the list of opportunities to improve health in populations that are at higher risk, and then do everything we can together to achieve the desired outcome.
Here is another question from your online audience, which is growing by the minute. What liability protection do you think will be provided them if they follow these guidelines, employers? This is what let me go back. I think Abe is saying, what guidelines will be coming from state for employers and what liability protection do you think will be provided them if they follow those guidelines?
I believe it's the governor's intention to provide those guidelines. What he said to us in his press conference last week is he's using a group of elected and appointed officials advised by business and healthcare leaders who represent communities across the state to formulate advice for businesses and for citizens that we can use to, again, move back towards normal. I believe the governor's intention is to create that playbook using the analogy I used at the outset, and then to ask communities and businesses, different organizations to use the playbook in the way that's most effective for them to accomplish their goals. The issue of liability is something I think we'll have to deal with over the course of time. But, in general, if we use recommendations that are coming forward based on best evidence, employ those to the best of our ability, it markedly reduces the potential liability.
I have another question, which is about, we're shifting again. Explain the antibody test, and will that be the heart of comprehensive testing?
Antibody testing is one of the forms of testing that we continue to explore. The first test that we had that could be employed broadly involved checking for the genetic material of the virus using this technique called PCR. That's the acronym. And what it does is to take a specimen, typically from the upper respiratory passage, and processes it so we can determine whether or not the virus is present in the patient. Now, we know viruses also cause a response in our immune systems. And a response in the immune system is to form antibodies. And so the antibody testing is designed to tell us, does someone have antibodies? If they have antibodies, there's a likelihood, pretty good likelihood, that they had the disease and they move beyond it. But the challenge of the antibody testing is we have to make sure it's specific enough so it truly identifies patients who have had COVID and not another sort of infection. And that it also can tell us, or perhaps can tell us, whether or not people actually have immunity.
That's what I was going to ask.
Disease. And right now, most of the antibody tests that we have are qualitative in terms they tell us that the antibodies are present, but they don't really tell us what they do, and they're not quantitative. They don't tell us how much antibody is present. The only scientific study that I'm aware of, I'm sure there's some that I'm not, but actually was done on monkeys in China.
Oh my God.
And looked at whether or not monkeys who had antibodies could be reinfected. And they were not reinfected, which was interpreted to mean that they had immunity on the basis of the antibodies being present. But even if immunity is present, how long does it last?
That was going to be my next question.
And
so we don't know.
Maybe this is like flu. We believe right now there are at least 8 different variants of the SARS-CoV-2 virus, the virus that causes COVID-19 illness. There may be more. Coronaviruses mutate over the course of time. So maybe this is going to be like flu, where we have to constantly adjust our approach to the use of a vaccine based on the variability in the virus. And so again, we have much to learn.
I have a question along those lines, which is, do we know demographically who this is most dangerous for? I mean, it sounds like, yes, people over 60. Are those numbers higher, for instance, than people who are in underserved populations that are in their 40s but have some diabetes? Is there a way to really target who is at the highest risk?
All great questions. And again,
Uh-huh.
hopefully we'll be able to answer those over the course of time.
Yeah.
Based on what we've seen around the world, we still believe what you said at the outset, beginning of the question is true. People who are older, people who have coexisting illness, who aren't as healthy as other members of the population seem to fare more poorly when they develop the infection. And so that's the more vulnerable population. And so as we go forward, we need to make sure that we identify ways to keep them safe too. And it may be that they need to have a higher level of social distancing than less vulnerable members of the population.
Yeah.
So again, things for us to think through. Now, if you look at the Texas numbers, interestingly, the greatest numbers of patients have been between the ages of 20 and 60.
Wow. Wow.
Is that a reflection of social distancing because older people have stayed home?
Yeah.
Really good question. So again, we still have much to learn.
Yeah, it'd be a great time to be an epidemiologist, I think.
Absolutely.
I think we have one more question. Well, I've sort of asked you this, but I'm going to ask again. I know there's great coordination in Houston's TMC. What is coordination like across Texas among hospital systems? It is slightly
we're fortunate in that we have strong groups like the Texas Medical Association, the Texas Hospital Association that represent all of us. And they are regularly engaged in communication with members, as well as the leaders of state agencies, the governor's office, the lieutenant governor's office, the speaker's office. And so that's probably the best way that we have to roll up a lot of feedback and also to disseminate information. And then certainly each of the counties has its own societies and member associations, and those are the next level, if you will. So Texas functions pretty well, at least among healthcare providers that way. We have a lot of different levels of associations and membership that allow us to share best practices, to share concerns, to communicate those, and then to collaborate more broadly. So that's a really great thing about our state.
Well, all fingers crossed. Thank you so much, Dr. Callender. This was terrific. It was fascinating.
Well, thank you so much for having me today.
Wonderful. Bye.